What about pressure? Well, when you use pressure controlled ventilation, you set a target pressure or a maximum pressure, and what varies is the volume, because the ventilator will push until it reaches a pressure of 25 and then it'll stop. It'll push until it reaches 25 and it'll stop. But it pushes gradually on a ramp, not a box, and so you typically have overall less airway pressures when you're using a pressure target than a volume target. Now, the best of both worlds is, what if the ventilator could consider both the pressure and the volume, and on a breath-to-breath basis, every breath, adjust itself to maximize both. And that exists now, basically this combined setting where you set a target tidal volume and you set a threshold for pressure, and the ventilator actually adjusts on a breath-to-breath basis depending on the resistance to meet your volume goals but not exceed your pressure goals. And this is, basically the best of both worlds. So what are our goals? And this is important, and write these down or make a note of them. So our goal with somebody that's mechanically ventilated is that we keep their pH above 7.2. So we're accepting acidosis and we're accepting hypercarbia. We want the SATs greater than 88%. They don't have to be 98%. They don't have to be 100%. We want a minimum of 88% or 89% saturations. Our plateau pressure, we want less than 35, and we'll talk about peak and plateau pressures. So peak pressure is the maximum pressure that the airways experience. So it's like the systolic of the blood pressure. And the plateau pressure is the diastolic pressure. It's basically the lowest pressure that the airways experience, and that's basically more important to us in terms of alveolar damage than the peak pressure. And to get the plateau pressure, some ventilators will calculate a plateau pressure, but usually you have to do an inspiratory pause to have the ventilator calculate the plateau pressure. So you have to ask your RT for a plateau pressure. And the other confounding thing is, usually you have to be on volume control to get a plateau pressure versus pressure control. But anyway, you need to know the difference between a peak pressure and a plateau pressure, because that's going to help us troubleshoot the vent when it starts alarming. So, and our goal is to get that FiO2 down to below 60% as quickly as possible. Why is that? So as Mike says, it's bad. So, it sounds like a terrorist group, but there's free radicals, and they basically cause cellular damage. And so the goal is to get that FiO2 down as quick as possible. So like your overdose patient, your 18-year-old that drank so much they're unconscious, you can start their vent at 50% or 40%. They don't need oxygen, they need ventilation. So you want to be very aggressive in lowering that FiO2 as quickly as possible. You only need a SAT of 89% or better. You want to get below 60% as quickly as possible to prevent secondary damage. And there's more and more research coming out about the dangers of oxygen. Okay, so the ARDS net study that probably everyone's familiar with looked at ARDS and what the optimal ventilation strategy was for that. And the secret was low tidal volume and high PEEP. That was the magic of managing ARDS patients. And over the years, basically the recommendation now is that all patients should be managed on an ARDS strategy, even if they have normal lungs. And that's why we have this very small cc per kilogram tidal volume. So basically, all patients should be started on 4 to 8 cc's per kilogram tidal volume. And this is ideal body weight. So sharpen your pencils. We're going to do a little math here in a second. So that's our ideal body weight is calculated. So males get credit for 50 kilos for the first 60 inches, females 45 kilos. So once you're past 5 feet, each additional inch of length adds 2.3 kilos of ideal body weight. So to finesse the vent, we have to know how tall the patient is. And there's always this guessing game about weight. Hey, doc, how much do you think the patient weighs? I suck at that game. I'm horrible at estimating weight, but I'm probably worst at estimating height. I kind of know if their feet are sticking off the end of the gurney, that they're 6'4" or something like that, but otherwise it's hard to tell. Some RTs have tape measures where they actually measure the patient's height, but you want to get a pretty accurate estimate of their height, because that translates into what you're going to set for your tidal volume. All right, so this picture is of this new concept. It's a bariatric training dummy, and what they did is they took lead powder and sewed it into this suit in the arms and legs, and basically this is a training dummy for EMS to use to simulate, our bariatric patient population.